Good evening and a warm welcome to all to this unique academic session of Maha AP Case Challenge. I welcome all the dignitaries who are present on this virtual Zoom platform as well as to our viewers who are watching it on YouTube Live. I acknowledge and welcome the presence of our Maha AP President Dr. Hemant Gangolia sir, convener Dr. Jay Bhandakar is also here, and Dr. Mahesh Moite sir, and our expert for today's session is Dr. Suhas Prabhu sir. Welcome you. The moderators, Dr. Rahul Patil sir and Dr. Mahesh Kore, and of course the participating teams of who are in the hot seat today are the team Palghar and team Thana. So I welcome you all, and I hope you will enjoy this unique academic sessions. So first I will go to Dr. Hemant Gangolia sir and invite him to make his presidential address.
Thank you, madam. Good evening, respected dignitaries and today's expert, our Dr. Suhas Prabhu sir, presenters Dr. Mahesh Kore sir, Dr. Rahul Patil. Two teams, team Thane and team Palghar, are today once again in the arena of today's Maha AP Case Challenge. And once again, high-level secrecy was maintained up to this point of time, and is still going to be maintained. Still, we don't know who is the presenter, who will be going to present to which team. This high-level secrecy, the credit goes to both madams, Dr. Sunita and Dr. Shilpa, and all the best wishes to both the teams. And let's see, the most important part is how do you approach the case in our practice rather than diagnosis. The approach to the case is very important, though practically more often we jump to the conclusions rather than the approach. Let's see how to learn that approach. Before that, on behalf of Maha AP Academy of Pediatrics, today we are going to release our second issue of Maha AP Bulletin at the worthy hands of our today's guest expert, Dr. Suhas Prabhu sir. And on behalf of we Maha AP should really congratulate Dr. editors, Dr. Neha Singh, Dr. Rajendra Chandurkar, Dr. Amol Pawar, as well as our digital wizard, Dr. Vishal Raut, and for the excellent compilation of this Maha AP second issue bulletin. It is consisting of almost 212 pages. And this 212 pages compilation, we can also thank to our Shankar, who is the computer boy from Neral, who has all designed all these things. But real credit goes for the last 24 hours to Dr. Neha, Dr. Vishal, to just make all the final compilation, So I will ask Dr. Neha to just display the first page of her Maha AP bulletin, and I will request our today's guest expert, Dr. Suhas Prabhu sir, to release this bulletin with his blessings. Yes, Dr. Neha, please share. Yes, Dr. Suhas Prabhu sir. Sir, please unmute yourself.
Thank you, Dr. Hemant, for inviting me, and all the office bearers of Maha AP for inviting me as an expert today and for asking me to release this bulletin. I have one comment, but I think it is misnamed. A bulletin cannot be 212 pages. This is more than any journal. I'm sure there are very wonderful articles in this. And I know how difficult it is to put together articles, and so it looks so attractive with such nice pictures. I also like the idea that it is bilingual. I can see some words in Marathi also. And I saw that on the main screen of Maha AP also. So I think that's a wonderful thing. And I know how much hard work goes into preparing even just one small booklet or one article. So I really must congratulate Dr. Neha and whoever else is involved in this. You mentioned the whole team. I'm sorry I don't remember all their names, but it's such a nice thing to do this. In today's age, where we are so used to getting everything done on the electronic media, and I must mention that every single message or communication regarding even today's program has been not even on email, was only on WhatsApp. So in today's age, when we are so used to looking at only the phone and messages, I think it's still worthy and worthwhile effort to make this kind of a bulletin. Because remember, the written word is much more permanent. This will be in the annals of the Maha AP, And these articles and details that are there will be remembered for a long time to come. So congratulations again. And I really think it's such a wonderful idea to have a bulletin so that the information is disseminated to all the members. I also congratulate the Maha Academy of Pediatrics of of Maharashtra, that they have opted to make it entirely electronic. I do think that in today's world, we should not waste paper. And most of the time, even paper journals just get put aside. Whereas I think what comes in our electronic media, we do look at much more often. But I would do request the Maharashtra State Branch to somewhere at least print one copy and keep it in their records so that future generations will see what wonderful work you have done. Thank you. And my pleasure to release this souvenir or bulletin today. Thank you very much.
Thank you, sir. And it really contains all the activities move of the branches. They are wonderfully conducted all across the Maharashtra. And I will request Dr. Neha just spend a half a minute to scroll and just tell a few words if she wants to comment on that.
Thank you, sir. Yes, sir. We have the team was there to do this bulletin, and there was Vishal sir who has done all the digitalization. Yes, the post where everything was put up by me, but at the end work was done by Vishal sir. And here we have all the messages from the dignitaries. Then we have the installation. About the installation, we had the Maha IP installation photographs and all. And then we have the other installation teams of branches. We have articles. This we have Maha IP, all the programs, whatever we have done from starting till June. We have tried to enter everything, and everything is clickable. When you will click on this now, you will get automatically, it will go to the site and you can see the video, everything here.
So all programs which were conducted by the branch, they have the links there, and the links are all linked. So whenever one clicks on that PDF file, it goes to that link and one can see all programs. So that is the greatness of this bulletin.
Thank you, sir.
Okay.
That's a wonderful bulletin, Neha. Great work on Neha and team. I must say, thank you so much, sir, for inaugurating it.
Yes.
Now we'll go towards the academic session. Yeah. Now I'll invite Dr. Moite, sir.
And we have.
Yes.
Yeah. Okay.
Yes, Dr. Neha, you can stop. Stop. Yes.
Sure. Dr. Moite, sir.
Yeah. Thank you very much, Dr. Ingari, madam, for this. First of all, I thank Dr. Prabhu sir to take the invite to become a judge here. I wanted him long back, but somehow he's so busy that it's very difficult to get him. So this time we right in the last month itself decided that we should be in touch, and that kind of work was given. The mission was given to both of this, Dr. Sunita Engade and Dr. Shilpa, and ultimately we got him. So thank you very much, sir. Sir has taught us so many things over the last 30 years, so many things. I mean, I always admire Dr. Ambedkar sir and Dr. Prabhu sir. Mumbai, these were the only 2-point kind of referrals over the years, and so many kind of approach. So they are right people to sort of take this kind of a judge position here as far as approach. Just I'm sure most of you by this time know the concept behind this. In the conferences, we see the cases being there in the panel and all, and invariably panelists know what cases is there and the approach, and everything is bypass and straightway reaching the diagnosis. And this is what in fact I saw in the postgraduate institutes also. Sometimes you go and see the case from the PG, and PG will say, sir, this is having 4 days fever and 2 days cough, and his X-ray showing this and his CBC showing this, that. They won't go into details of the case. So we wanted some kind of an approach like our Science PG clinic by Dr. Ambedkar sir, wherein just spend good time on the history and try to click 80% of the cases just based on the history from the clinical approach. And then the investigation, your clinical examination adding maybe another 20%, and investigation is just to probably confirm your diagnosis. So that kind of an approach we want in a live case. So here is that. In fact, if you see our flyers, that won't mention which district. So we had 36 districts of the state. Each district will be taking a challenge, and person from other district will be presenting a case. And even today, many of them may not be knowing which district is presenting and which district is taking the challenge, because we wanted to keep that total secrecy. Those cases are known probably only to me and the presenter, not even Neha, not even Dr. Sunita and this Shilpa is knowing those cases. So that level of secrecy. And just now also, even the presenter don't know which team is going to present. So that ultimately will be presented by Shilpa. So that's the way we are maintained it. That will give a really high level of secrecy, as well as then we'll have a really genuine approach to the case. So whole concept is a clinical approach. There is nothing, you may or may not click the diagnosis, but believe me, this is, I think, 7th, 8th session, Hemant. This is the
8th session. 8th.
14 cases presented so far, and 13 of the times the cases were diagnosed by our panelists from various districts. 13 times they have been diagnosed just on the clinical examination. So we have huge talent in Maharashtra IIP. They can do it. I'm sure they must be doing day in, day out practice. Unfortunately, very few of are coming to the presenters' dais and the conferences. So we have few really gems coming out of this to the dais, and they have presented in the last year's Mahapedicon. And I'm sure I'll get more and more fantastic faculties from this group who are actually genuine faculty. So with that, I hand it over to Dr. Shilpa to take the proceeding further. Again, thank you again, Dr. Prabhu sir, of course, my dear friend, Dr. Hemant, Dr. Jay, and many others who are on the dais. And of course, I am seeing Mahesh very eagerly waiting to present. So this man is another gem, amazing academician. Believe me, they are all wonderful people. Dr. Pramod Kulkarni is also, I'm seeing, I'm just naming this because I know them. I'm sure there are many more beyond this list who are doing equally wonderful job all along. So thank you very much for this. And I'm sure this is our penultimate session. Next session is going to be a grand finale. So here in that session, just to declare before closure, maybe myself and one of my friend will be presenting the cases, and we are inviting the faculty. It's not district. So maybe very senior people will be invited from whatever 8 sessions we had. The select people will be invited to take the challenge, and I'm sure that will be a good grand finale. So thank you very much for the opportunity given, Dr. Hemant. Over to you.
Dr. Prabhu sir, it all started with Mahapedicon, this case challenge scenarios, and it all started with Mahapedicon I held at Alibag, where you were there. And our last episode will be 9th one, and we'll be having grand finale. I thought, let us have a exact this how one should go, the ideal one, so that Dr. Moiti sir will be looking after. Thank you much.
Thank you so much, sir. Now, it is my pleasant duty to introduce Dr. Suhas Prabhu sir. I mean, we are very fortunate to have him with us today, as he's a great academician who holds infectious diseases close to his heart. Dr. Prabhu sir is a consultant pediatrician at PD Hinduja Hospital, Mumbai since 1986. He's been the honorary pediatrician and HOD of the pediatric department, Baba Hospital, Mumbai. Sir is a co-author of GEMS, that is the group education module on childhood TB, EPID, and antimicrobial stewardship program. Sir is the editor of the antibiotic section in the Pediatric Infectious Disease Journal. He is the recipient of 9 orations, is the author of over 50 publications and chapters in books. He is a co-editor of textbook of rational antibiotic practice as well as evidence-based practice in pediatric infectious diseases. Recently, sir was the chairperson of Government of Maharashtra Task Force. Kindly mute yourself, please. Recently, sir was the chairperson of the Government of Maharashtra Task Force for tackling the 3rd wave of COVID in children. We welcome you, sir. And sir, please give best wishes to our participating teams and the moderators. Over to you, sir. Kindly unmute yourself.
Thank you. Thank you for inviting me, as I said earlier. And I must say a few words about this concept. I know Mahesh for very long, and I also know Mahesh always is the clinician at heart. And I think that's very important. Like I see that in this type of module, the answer is not important. The approach is more important. We've all heard Amdekar sir do it on every Thursday for so many years, but we know that, and now of course it is online also, but it's a great idea that Maha IIP is doing this. Mahesh, that's a wonderful thing you're doing. I keep telling my residents also that when you present a case, the diagnosis is not important. I have been an examiner also a couple of times for postgraduate exams. And it has always been my endeavor to see what the approach was. even if he made some errors in the final diagnosis, that is not important. We are not omnipotent. We ultimately have to rely on certain investigations to prove or disprove our clinical diagnosis. The approach and thought process is important, particularly in today's day, where I see people look at reports first and don't look at the patients at all. And I am thankful again to Maha IAP for giving me the opportunity to elaborate on this. I will be speaking more on this at the oration at the Mahapedicon in Nashik in November. And I've chosen this similar topic, so I will try and expand on that. But congratulations again, Mahesh, for a wonderful format. And I'm sure we're going to have a very interesting time. Thank you.
Thank you so much, sir. Now I'll hand over to Shilpa. Shilpa, are you there?
Yeah.
Yeah. Go ahead.
Hello, ma'am. Thank you, ma'am. Good evening to all the respected seniors who are joined with us today. This is our 8th session of Maha IAP case challenges. Today with us, we have our 2 very excited team and moderators with their interesting cases. So our moderators for today are Dr. Mahesh Kore, sir. Sir is a senior consultant in Shri Hospital in the district of Belgavi, and his areas of interest are rheumatology, brucellosis, IEM. He has various publications and a chapter to his name in the textbook of IAP Pediatrics. Our second moderator for today is Dr. Rahul Patil, sir, and he is the director at Tarangan Child Care, Jalgaon, and he's a consultant intensivist at Niramaya Hospital, Jalgaon. So our team from today are Dr. Geeta Bhatt, ma'am, Dr. Archana Kawalkat, sir, ma'am, and Dr. Rishikesh Dingankar, sir. They are from Thane. And from Palghar team, we have with us Dr. Mahesh Mate, sir, Dr. Ankit Gupta, sir, and Dr. Shailesh Barot, sir. So thank you so much for joining, for your active participation. Reminded to everybody who's watching the session to kindly keep yourself on mute. Only the presenter and the team who is being asked have to be kept on, have to be unmute during the session. Not to post any answers on the chat box. And if you have any questions, we will try to answer it at the end of the session. So for each case, we will have 25 minutes for the presentation and discussion, and next 5 minutes would be for expert comments. So let's not waste any more time and start with our session. So for our first session, I invite Dr. Mahesh Kore, sir, to please unmute and share his presentation. And he will be giving this case to team Palghar. That is Dr. Mahesh Mate, Dr. Ankit Gupta, and Dr. Shailesh Barot, sir. Kindly unmute yourself.
Thank you, Maha IP, for inviting me. And I'll be just sharing my screen. Are you able to see my screen?
Yes, sir.
Yes, sir.
Should we start?
Yes, sir.
This was a child born in government hospital Nipani, full-term cesarean section, cried immediately after birth. And this is a girl child. And for 23 days, she was normal. On 23rd day, she had vomiting, refusal of feed, and acute parazole event, 1 episode. And she visited our hospital. Vomiting was non-bilious, 5 to 6 times in a day. She was lethargic, cry tone activity was poor, but there was no neonatal encephalopathy or trauma, birth trauma specifically. So, which team I am talking to?
Palghar, sir.
Palghar team can put their thoughts on this scenario. 23 days old girl child had a vomiting, refusal of feeds, and 1 acute parazole event, must be seizure.
Sir, we can think of late onset sepsis as one of the differential diagnoses.
Yes.
Because of vomiting, lethargy, and one episode of seizure. Second thing we can think of is any metabolic events like because of vomiting, lethargy, hypoglycemia or hyponatremia or that type of thing. And third thing, if at all the things are normal, then we can think of IEM as one of the presenting feature because 23 days on feeds. Hello, 23
Hello.
days
Yeah.
on feeds and came with lethargy, vomiting, and convulsion. So one of the thing will be inborn error of metabolism.
Yeah. Absolutely right thinking. Sepsis, but there was no fever. So sepsis will come prior or IEM will come prior?
IEM will come prior. This looks more of the pathological jaundice. And the first
No, I have not told about jaundice. That heading was neonatal with hyperemia, but there is at present we are not talking about jaundice right now.
It looks more of the inborn error of metabolism with probable hepatic encephalopathy.
And she had only one episode of vomiting, or it was recurrent?
3-4 times or 5-6 times. This was 5 to 6 times.
So, yeah, although she is a girl child, but I would also like think of CHPS also. Just
okay, non-bilious vomiting, but convulsions will not be that common in CHPS or IHPS.
Yeah.
Okay, so we'll go further. She had a poor tone activity. Pulse was tachycardic, but AF was tense. And BP was maintained. She had mild jaundice. Liver was just palpable, but at present soft only. Spleen is also not palpable. Sinus movements of both hands and legs are normal. Heart sounds normal, no murmur, RS normal. What you add to your thinking, or you're thinking something differently? Now mild jaundice is there and AF is tense.
Yes, her vitals are okay.
Okay.
So there is no tachycardia, there is no respiratory distress, her BP is well maintained. So again, I will not go in favor of sepsis in this child, even though AF is tense. So in mild jaundice with AF tense, again the liver is not just palpable. So again, all other causes of storage disorders and everything goes out with the jaundice part of it. The thing AF is tense.
She has tense AF and she has convulsions also. So
Yeah.
some localizing to
some hemorrhage or something like that.
Absolutely. And what is the cause of that hemorrhage? Most probably, you're right. Absolutely.
Some hemorrhagic disorder.
Hemorrhagic disease of newborn. You're thinking of right present.
Yeah.
Okay.
You have not mentioned, is she pale?
Yeah. Poor cry. Yeah. Mild pallor was there, but that was not that significant because she was convulsing at that time. That's why.
What is ophthalmic examination?
Ophthalmic examination was not done, sir.
Okay.
Why you're interested? Why you're interested?
Probably galactosemia.
But there was no liver.
No liver.
Cataract. There was no cataract. Yeah, you want to ask about cataract was present or not? Yeah, there was no cataract. But with this history of 2 days of vomiting, ill-looking child, convulsions, and AF is tense, your first diagnosis will be what you said?
Late onset hemorrhagic disease of newborn.
Yeah, absolutely right. And that was our also thinking we are dealing with some vitamin K deficiency or vitamin K dependent factors are less, and she had a late onset hemorrhagic disease. So this child was admitted, and this was a investigations. Hemoglobin was dropped down, counts were normal, platelets are normal, no abnormal cells. Bilirubin is direct 1, ALT is mildly raised, and pro-time is deranged. INR is 2.4, APTT is also high, blood urea and creatinine normal. Now what are you thinking?
You have measured her ammonia?
These are the present investigation what we have.
Okay.
Still, I'll go in favor of late onset hemorrhagic disease because of the abnormal PT and PT, INR, and APTT.
Okay.
Or maybe some early onset bleeding disorders. We'll keep it in mind.
What are the
Sir,
other differential
even
diagnoses in your
IM
mind?
Sir, IM also we should
Yeah,
think.
which are the IMs you are thinking of now with this?
Maybe your urea cycle defects.
Urea cycle defect will present with jaundice and hemorrhage?
No, it will not.
Yes. Okay, but urea cycle is one of the differential. What do you think that this child is in acute liver failure?
That's what I wanted. The ammonia could be, she could be in liver
No.
cell failure.
Acute liver failure, ammonia is not needed for acute liver failure.
Okay,
Only
no, she's encephalopathic. Her INR is 2.46. So yeah, she does, and her trans OTPT, although they are normal.
Okay. So we will go ahead. Your thinking is right. You are right on track. You are thinking of IEM, but at present she was in acute liver failure. But we define acute liver failure in neonate like not corrected PT. You have to give 2 doses of vitamin K, and then you have to repeat the PT. And if it is more than 1.5, normally is pointed to 1.2.
Yeah.
If it is more than that, you can call it as acute liver failure. So with ultrasonography, brain was done, and there was grade 3 germinal matrix hemorrhage. Okay, and USG abdominal was normal, and she was given vitamin K, FFP, and she recovered very well. What you should have done?
We should have you measured her lactates? Lactates and ammonia, we should think.
Okay, and what are your thought? Why you want lactate and ammonia? You're right. Why you want lactate and ammonia?
Because again, IEM is what we have to think at this age group.
Yeah, but which is a simple test that we can do bedside or in a simple lab also where ammonia is not available. So you are thinking of IM, and which are the common IM treatable IM in a newborn period with acute liver failure? You said one cataract. You are looking for cataract, no?
Yeah, this tyrosinemias and
galactosemia, tyrosinemia. Yeah. So for galactosemia, what you will do in a routine lab?
The reducing
urine for reducing substance by Benedict and by dipsticks. Okay. Yeah. So that will give, that is a simple test, and you're right, ammonia and lactate you want. Now the child was all right, and they came to us, and there was a family history that Attas means father, sister, third issue of non-consanguineous marriage, had a biliary atresia and operated at 3 months and expired at 1.5 years of age. This is the first issue of non-consanguineous marriage. Does this add to your diagnosis or you modify your diagnosis sometime? Okay, this you used to remember like this. This baby had been operated for biliary atresia and but
basically
expired.
There is history of death in the family. Early death is there in the family, so it should ring a bell that baby could be having some underlying genetic issues.
Okay, good. That is good enough. Now this was a chart that baby was operated for biliary, and both these are non-consanguineous marriages, but NICU care was given, vitamin K, FFP, anticonvulsant, IV fluids, antibiotic, and baby was discharged.
And your INR improved with vitamin K, sir. Your INR improved with
INR improved. INR improved with vitamin K. So what you will think if INR is not improved with vitamin K and if INR improved with vitamin K? What are your thinking? If INR is not improved, then what you will think? You're right.
Again, so it is going in more of the severity of liver cell failure.
Yeah, you say you'll label this as an acute liver cell failure or acute liver failure, and you'll search for the metabolic causes of acute liver cell failure. And you already mentioned galactosemia and tyrosinemia. These are the two. I want more from you. Which are other?
Sugars were
okay. If sugars were low, then what will you think?
We'll think of fatty acid oxidation defects.
Fatty acid oxidation defect. Okay, but they will present slightly later, and they have a different presentation because fatty acid will have all these metabolic disorders. Other. Okay, that is one right. Fatty acid oxidation defect. Anything else you'll think of? If the child presents in a first week itself with liver cell failure, what is your thoughts?
First week, actually, neonate is not my forte.
Okay, okay. We'll go ahead. Okay. Neonatal hemochromatosis or gall karke rehta hai, that will present in a early neonatal period. Okay. The child has jaundice now at 1 month, 2 days of age and high color urine, and stools are now yellow color. And active baby sucking well at breast, vital stables, liver just palpable, rest of the system examination is normal. So what we will do next? Now the stable baby with jaundice and yellow urine.
Investigations?
Yeah. These are the investigations. Again, jaundice, mild jaundice, SGPT-OT, mildly raised. Alkaline phosphate is also raised. So what you are thinking?
This is
You thinking of cholestatic jaundice at this stage?
Cholestatic jaundice.
Okay.
Cholestatic
What you will
jaundice.
do? For cholestatic jaundice, what you will do?
Liver scan.
Yeah, it shows cholestatic jaundice, LP was high. Ultrasonography was done to look for a biliary atresia, triangular cord sign, and that was not there. And provisional diagnosis was cholestatic jaundice under investigations. So next step will be
HIDA scan.
HIDA scan. Yes, we are advised to consult hepatologist because there was history of biliary atresia in a family. But parents were worried about liver biopsy and need for operation, and it didn't go. Okay. And this we have done. You are told that urinary reducing substance for by Benedict test and glucose tests for 3 days. We have done, and that was negative. And HIDA scan, as you asked, HIDA scan was done, and that was showing mild stresses of dye in a gut. So biliary atresia is ruled out. So now you have cholestatic jaundice. Okay, so what are the groups of cholestatic jaundice will be? One is biliary atresia and surgical causes, obstruction. Second group will be other causes of cholestatic jaundice.
Cholestatic jaundice. Yeah.
Which are they? And how will you proceed? Can you think of again IM here?
Torch infection.
Torch infection, yes. Torch infection is one of the group, that infective disorder which can cause cholestatic jaundice. Other is obstructive, surgical causes of cholestatic jaundice. They are not there. And one more group, that is IEM, can be thought of. So which are the IEM can present with cholestatic jaundice?
Tyrosinemia.
Tyrosinemia will present with liver cell failure, as you are rightly told. That will be more of a PT more prolonged than the SGPT-OT, because SGPT-OT are not that disturbed in tyrosinemia, and they have a large kidneys, and hepatorenal syndrome will be there.
These neonatal hemochromatosis and all those things.
Okay, neonatal hemochromatosis will present with liver cell failure, but see, the BB has recovered very well with that vitamin K and FFP. So that child was not in now liver cell failure.
About sir, the thyroid have we done, or?
Yeah, thyroid has been done, and that was normal. You're absolutely right. That we have taken care of.
Have we done ABG, sir? ABG?
ABG was normal in this child. Because that child was normal now, active, playful, only mild jaundice, that is cholestatic jaundice, and sucking at breast very well.
This cystic fibrosis, and did she pass stools in the first 24 hours?
Yeah, absolutely. Cystic fibrosis sometimes can cause this type of milder jaundice and cholestatic, but she has passed stools and there was no meconium ileus, and there was no metabolic alkalosis also as in cystic, expectant cystic fibrosis.
Bile acid disorders.
Bile acid disorders, yes,
Yeah.
bile acid disorders sometimes can present with this type of. This was a child.
PFIC and all these.
Yeah, absolutely. Why you thought of PFIC? Absolutely right. Why you thought of?
The hint lies because actually we see these PFIC cases. It is your your OTPT and the bilirubin and the alkaline phosphatase. It has something to do with that. In that, I think in PFIC your alkaline phosphatase is bit on the higher side. Huh?
And which is the enzyme, which is the test you will do for PFIC? You are right. Absolutely right.
PFIC you need to. GGT. GGT would be low. GGT would be, I think it would be low in.
Absolutely, that's fine. If you don't remember also GGT, in which cases GGT is normal,
yeah,
in which cases GGT is
there.
But absolutely fine. In this case, GGT was normal, and that give a clue that we are dealing with
PFIC 2 or.
You have to remember 1 and 2 will be normal, 3 is higher, that 3 will be higher. Okay, so this was a chart: infantile cholestatic disorder and jaundice with pruritus. Now, pruritus will be because of bile acid and bile salts. If you have to do LFT, GGT, and biliary imaging, if high alkaline phosphatase, low GGT, and biliary system normal on ultrasonography, you are dealing with PFIC 1 and 2. If high alkaline phosphatase and GGT also and biliary system normal, you may be dealing with allegedly, which will have heart disease and butterfly vertebrae, PFIC 3 and alpha-1 antitrypsin, which is not seen in India. So you are left with only PFIC 3 and Allegedly syndrome. Okay, high GGT and high alkaline phosphatase and GGT and abnormal biliary, choledochal cyst, sclerosing cholangitis, all this. So this has given us a diagnosis that we are dealing with PFIC, and you are also right. You are thinking of PFIC, and we are proved by clinical exome sequencing, and this was our first case of PFIC 2, which is more common. Okay, and one more case immediately, and we have done a GGT, and that clinches the diagnosis. So the GGT is more important in differentiating this PFIC 1 and 2 from 3, and you have done it. Prabhu sir, do you want to have some comment?
Sir, kindly unmute yourself.
I will stop my sharing.
Yes.
No, I think this is a very interesting case, very unusual case, of course, rare case. So congratulations that the team has narrowed down to the diagnosis.
Yeah, absolutely.
But as I mentioned right in the beginning, I think the approach is where everything starts. So I would have expected this team to be much more aggressive right in the beginning. That, I mean, I don't know what the format actually is, but I didn't hear when the people said, when Mahesh said that the symptoms started in newborn period, one of the first things I think would ask is, was there consanguinity? I didn't hear the team ask for that. That was a little unusual. So I think that's very important. When you have a child presenting with unusual symptoms, where you might think of a hereditary disorder of any kind, consanguinity is very important. Now, in this case, there wasn't, and it still turned out to be autosomal recessive. That's a different issue. But I think we must ask for history of consanguinity. The second point I wanted to make is the fact that, I mean, they rightly pointed out three important things. I mean, the third one came a little late when the child was initially presented. Late onset sepsis, hypoglycemia, inborn error of metabolism, and of course, later on came the late HDN. So I think while I agree that there was no fever, I do think, and I always my principle that think of common things first. We do know that sepsis is much, much more common than IEM or PFIC, leave alone anything else. So, and we know that fever in a neonate, sepsis in a neonate can occur without fever. So we should think of sepsis first. and think of IEM later. So the second thing. Third is the issue about late HDN. I think it's important to ask two questions which were not asked here. Did the child receive vitamin K after birth? And whether the child was top fed or breastfed. I think two very important clues that will tell you that HDN, late HDN, we know can happen if vitamin K is not given at birth. Should never happen, but we know that it still occasionally happens in our country because for some reason it is missed. So this issue about whether vitamin K was given at birth and whether the baby is top fed or breastfed was missed. So that's the other thing. A few other comments I wanted to make is the fact that although the sibling had biliary atresia has no hereditary pattern. So therefore very unlikely to expect that this child also had biliary atresia. But I am wondering whether that child also did not have biliary atresia and had PFIC, which was misdiagnosed. That would be my thought, because I don't know.
That
who
was
diagnosed
our
that.
thought.
Yeah, it's very likely. Very likely.
Yeah, probably that was not a biliary atresia.
Yes,
and
it might be PFIC, and it was missed.
PFIC only.
And two more important points I want to say. One is the fact that when we talk about LFT, we typically, for some reason, tend to do a shortcut LFT. And I think here we saw the consequences of doing a shortcut LFT. Just do the bilirubin, just do the SGPT-OT. I don't think that constitutes a full LFT. While sometimes you may think that's a waste to do all these things, I know that in today's era, where everything is more or less automated, the price cost is not very much different and you can do it all on a small amount of blood. So when you do an LFT, please ask for everything, including the GGT and alk-phos. If that was seen earlier, I think this answer would have been much more obvious. And one small point I wanted to make is that while we discussed hypothyroidism here, typically hypothyroidism shows indirect jaundice rather than cholestatic.
Unconjugated.
So these are the points that I wanted to make. But congratulations for the team that did narrow on to a very rare diagnosis. Thank you.
Thank you so much, sir.
Thank you so much, sir. That was really very good inputs that we got from, and what all were missed were highlighted. That is much more important for for our learning. Dr. Mahesh, sir, do you want to comment? Mahesh Mohite, sir?
No, I think Sarah has almost summed up everything. Just I was, while they were presenting, I was just writing my own algorithm. Maybe coming on day 23 with kind of unrelated symptom, but not encephalopathic to start with, but later on become a bit lethargic and all. And what was clearly there in the first slide itself was a cholestatic jaundice with a deranged PT-INR. Obviously, the algorithm starts from here. I am looking at cholestasis. So I will be giving vitamin K to this patient. If there is no improvement in that, it is hepatic or hepatocyte failure. If there is improvement in that, then I'm looking at a biliary obstruction. Next thing I do is a USG. If I get an abnormality in the extrahepatic, so it's either intrahepatic or extrahepatic. If it is extrahepatic, then I'm going to pick it up in the USG. If it is intrahepatic, I'm unlikely to pick it up. So next thing I do is GGT. If the GGT is high, I have limited abnormalities. I could be having a biliary atresia. I could be having positive biliary canalicular alagines. You may be having cholangitis, but this child was not febrile, toxic or nothing. And if the GGT is normal, and of course the PFIC3, which Mahesh said, which is because of the bile salt being active in the PFIC3. And if the GGT is normal in spite of cholestasis, which is corrected, obviously you are onto PFIC1 and 2. I don't think we can go beyond that. So you can have design your own simple algorithm for approaching a cholestatic jaundice, and rest all has been very nicely said by Dr. Prabhu sir. Thank you very much.
Thank you, Mahesh Kore, sir, for such a wonderful case, sharing this with us. And congratulations, Team Palghar. You have actually narrowed down to a diagnosis and within time. So moving on to our next case. So for our next case, I would like to invite Dr. Rahul Patil, sir. Sir, please share your presentation, and Team Palghar, that is Dr. Archana ma'am, Geeta ma'am, and Rishikesh sir. Thane, sorry. I'm sorry, Thane.
Thank you very much, Maha AP, for giving us this opportunity And I thank Jalgaon IAP also for giving me this opportunity to present the case from on behalf of Jalgaon IAP. So,
Sir,
shall I
can you
start?
make it slideshow? Yes.
Slideshow.
Nice, sir. Yeah.
Yeah.
It has to.
Can you see now?
Sir, we can see, but
Otherwise, do from beginning. Slideshow upper ka, from beginning karo.
Yes, sir. I did.
double click karo. Double click karo.
Okay. Yes, sir.
Some problem is there. Apple hai ka?
Go to the bottom and collect one of those three last icon. Go to the line.
No, sir, तिथे नाही होणार.
You are seeing three icons of slide,
yeah,
multiple
near
slide and a
the
screen.
resolution.
Okay. Apple's a problem.
On the right side,
No,
bottom.
Rahul,
He
go
tried
to the
doing that.
bottom.
He
Yeah,
tried
go to
doing
the
that. He tried
come
doing
down,
that.
come down. On the right side, Those three icons you are seeing, click the last one.
This one?
So
No,
where
he
is your
he tried
cursor?
actually first, but it's
He
didn't
tried.
go.
Okay.
1 minute. I will go back and I will start it again.
I think so. You
Yeah.
close and do again. Open your PPT, keep ready on the desktop, and then share.
Is it visible, sir? Now I have just done it again.
It is visible, but double click करो, full screen हो जाएगा.
Duration.
Do double click there.
But sir, already I can see a slideshow started from my side.
Then you do one thing. When you stop sharing
Okay.
करा.
Okay.
आणि शेअर करताना तुम्हाला दोन पीपीटी दिसतात का? परत शेअरचा क्लिक आयकॉन क्लिक करा.
Yes, sir.
दोन
Yes.
दिसतात ते फुल स्क्रीन वाल्याला क्लिक करा.
Okay.
दोन पीपीटी दिसत असेल तुम्हाला समोर, त्याच्यामध्ये जे फुल स्क्रीन दिसत त्याला क्लिक करा. डबल क्लिक करा आणि त्याला क्लिक करून शेअर करा.
होतंय का सर?
नाही.
शेअर नाही झालं.
Have you sent the PPT to any of the for
You
backup?
can send the PPT to Shilpa madam and she'll project it for you.
Okay.
आता तुम्ही पीपीटी क्लिक करा. Slide show kara.
Yes, sir, now.
Done.
Okay.
It's done now.
Okay. Can you start?
Yes, sir, start.
Okay. So just sharing this one of the interesting case. He's a 4 years old boy born of 3rd degree consanguinity. Birth weight was 2.8 kg. He was brought to us with complaints of anasarca since 15 days, delayed development, chronic skin disorder since early infancy, and irritability. Let's see the complaints in detail. Anasarca, it was started 15 days ago. Before that, child was not absolutely normal. He was well. Edema was more in the morning, involving the facial and the whole body, more on the legs. but as the day passes, it was decreases in the evening. There was no associated decrease in the urine output, no discoloration of the urine, not associated with any difficulty breathing or any jaundice, and no such edema episodes were there in the past. Child remains irritable most of the time since many days, but cannot exactly tell since when. The informers were both the parents. Regarding delayed development, among gross motor, he started sitting at 1 year, then standing at 2 years, and then started walking by 2.5 years. He was able to walk for the next 1 year, up to 3.5 years. But later he stopped walking since 1 year. Now he is 4.5 years, we have seen. And now he is able to just sit now. He moves hands voluntarily, but not moving legs and cannot stand at this point. Among fine motors, detailed stages, the parents don't remember exactly, but right now he is able to feed himself properly. He can hold pen, scribble, draw few figures, clothing with some assistance from the mother. Among speech and cognition, there is a delayed start of speech after 18 months. Now he can speak sentences with meaning, responds appropriately, and can converse relevantly. Am I getting too fast or is it okay?
No, it's fine.
No, it's okay.
Yeah, okay. Regarding skin rash, he was all right till 3 months. Means he's 3 months of age. The photographs are shown by the parents, and then started this rash on body all over. Presently, the rash is erythematous reddish. There is itching pruritic rash with peeling of the skin, but there is no ulcerations over it. He was diagnosed as an infantile cirrhosis and treated by 2 different separate dermatologists and 3 pediatricians before shifting to us. The prescriptions showed multiple steroid ointment, systemic steroid prescriptions in the initial 2 to 3 years, not in the last 1 year. So even after going with all these management, the parents, they stopped showing child to anywhere else. So last 1 year, they didn't go anywhere else. And later on, they came to us with some hope they will get some at least new treatment. There was no history suggestive of any skin infection. No history suggestive of altered sensorium or seizure in the whole spectrum of this disease. No facial movement difficulty reported by the parents. Reports pain in the trunks and the limbs intermittently. He is able to indicate his bowel bladder and dry by day most of the time. There is no history of any recurrent ear infections and no history suggestive of recurrent systemic infection. Like he didn't need any hospitalization in the past. So this part is okay. So what are the thoughts you're getting from this history or anything else you need?
So, can you give us a bit of the birth history? What was the birth weight of the child? And was there any concern?
Yeah, ma'am. In the very first slide, he was born of 3rd degree consanguinity. His birth weight was 2.8 kg. Child cried after birth, no NICU stay, and he was breastfed nicely in the initial 5 months of age, direct breastfed, and then gradual weaning started.
And anything in the family history you can give us? Anything in the family history?
No, madam. There was no such any similar illness or any other significant illness in the family. What do you expect from the family history, ma'am?
No, we are seeing a child with delayed milestones and some skin lesions. We are seeing some regression in physical milestones, we want to know if there is any familial, some hereditary thing that is being passed on.
No, madam. No. There was no such history.
What is the current weight? What is the current weight and the height of the child, and how is the growth of the child?
Yeah,
because
I'll come to that in
very low.
Yeah, I'll come to that in the later anthropometry. It's there in the next. They belong to the upper middle class, so there is no. And dietary intake among that, he was able to take around 400 to 500 kilocalorie per day, and proteins around 8 to 10 grams of protein per day. His weight was around 20 kg, madam. I'll go to the next
around
slide.
20 kg at 4.5 years, no?
Yes, madam. Yes.
just one or two
Summarize.
questions. In the rash appeared after 3 months of age.
Yes,
And
ma'am.
right now he's 4.5 years of age, right?
Yes.
So the rash is almost prolonged for almost 4 years,
years of
and 3
life.
months almost.
Yes,
That's what you
yes.
are trying to
Yes,
tell
ma'am.
us, right?
Yes.
And is it persistent? Is it like
Waxing and
waxing and waning?
No,
Is
ma'am.
it-
It's not waxing and waning. It is persistence and it is progressively increasing. Though the progression is very slow, but it started to begin with erythema, then gradual itching, and then later healing of the skin overall. And along with that,
The
edema,
distribution of the rash.
it's all over the
Distribution
body.
of the rash.
It's all over the
It's
body.
all over
but
the body.
Yes, it's all over the body, including face, palms,
And
and
along
chest.
itching, along with
Yes.
that itching is there.
Yes, madam. Yes.
So just to summarize, this was the child who is basically a developmental delay. Here in the birth history, we just want to know he's cried immediately after birth.
Yes,
There has
ma'am.
been no perinatal, there is no
Insult. There
history
is no
which can,
perinatal insult. No.
to point out his developmental
Yes,
delay
yes,
course
yes.
or HI.
Yeah.
So he is a child who is right now presenting with anasarca, a known child who is developmental delay, but we see that the motor milestones are regressed. There
Yes.
were obviously delay in achieving the motor milestones, but last 1 year the motor milestones are also regressed, but
Yes.
his speech is not regressed, and
Yes.
he's otherwise, his speech is getting better.
Yes, ma'am. Rightly said. His
So-
speech and cognition is good, but more maximum the gross motor things are affected, and rather there is some regression.
So with regards to this motor milestones getting delayed with a developmental delay child with a diet of only 400-500 kilocalories per day and a protein of only 8 to 10 gram proteins per day,
Yes,
it is
madam.
definitely quite deficient with proteins and also with the calories.
Yes.
So some amount of nutritional component can be there for his general ill health, which has been happening. And even the proteins being so low, that can be one of the factors for his anasarca, like an
Perfect.
hypoproteinemia.
Perfect,
And
ma'am. Rightly said.
micronutrient deficiency with
Micronutrient
relation to the skin lesions that we are talking about. Although he comes from an upper middle class, the diet as well as this. So there's protein gap, there is calorie gap, and there is micronutrient gap.
Right. ma'am.
One more thing that we felt was that why has the physical milestone gotten delayed? Could it be because of again vitamin D, hypocalcemia, etc.? Or also you mentioned that there are steroids being given, multiple courses
Yes,
of
yes,
steroids,
Yeah,
oral
among medication,
steroids which
multiple
are given.
steroids. Systemic as well as
could they
topical
have
steroids were
contributed to
given.
a myopathy?
Yeah, that could also add to myopathy for this
So
child.
these are the thoughts that are coming.
And only for one more thing for the rash, since this rash is going on for such a long period, appears to be a chronic rash, the chances of it being more in terms of an immunological component
is more likely
rather than,
Just nutrition,
related to
rather than just
nutrition
nutrition.
or infection or, which are like acute
Yes, ma'am. Yes,
part of the
rightly
rash.
so.
You said that he doesn't suffer from repeated infections, isn't it?
No, ma'am. No, there was
No,
no
there are no
hospitalization. It was
no
just
repeated.
OPD visits. These were those OPD visits, no hospitalization.
Correct. So
So no
immunodeficiency looks less
immunodeficiency
likely.
per se, just the rash is the thing that seems to be the problem.
Yes, ma'am. So till now, what we have seen is delayed developmental with some gross motor regression of the gross motor milestones. Second, speech cognition is normal. So he is a bit malnourished and rash can be.
So why is the diet so low? Why is the diet calories intake so low? Is it because
That
it's
is
an
what the
upper
diet
source
the
of
parents
protein?
were giving there. That is the diet parents
Okay.
were giving to the child, and he was also not taking it well properly because of some anorexia.
So there is feeding difficulty. Was there feeding difficulty?
No. He was able to take it very nicely, sir. No, that was not an issue.
They were giving only 500 calories.
When was he weaned off breast milk, and when was he
But-
weaned off breastfeeding?
After 5 months, it started, and almost up to 1.5 years, he was breastfed. Along with the baki
1.5 year
complementary feeds.
breastfed, and
Yes.
complementary feeds were not introduced, is it?
No. Complementary feeds were introduced earlier in the infantile around 6 months, but breastfeed was continued till around 1 to 1.5 years of age. And he was taking it.
Did he receive?
Sorry.
No. You complete, then I'll ask. You were saying something.
No, that's what, ma'am, sir. The complementary
He was
feeding
taking
started
he was
around-
accepting.
Yes, child was accepting feeds well.
Accepting.
And in addition to that, he was given this pasteurized milk. In between night time, he used to take pasteurized milk.
So were there any GI symptoms, any
Intermittently, he used to
GI
get
losses, gastroenteritis, vomiting, etc. Because he's not growing so well. So
Weight is 20, but that could be edema.
20, yeah,
Anasarca.
that is edema.
Was it the weight before anasarca? Do you have any weight? This is weight is 20, which is okay for a 4-year-old, but could be because of the anasarca.
Ha, sir. Sorry, his weight was 12 kg. Why Mr. Guy said 20 kg? It
20.
was 12 kg.
You
You said 20 kgs. So
It was 12 kg. Sorry.
12
It was 12 kg. 12
So
kg.
there is gross mass. Okay.
yeah.
So, there is
So that's
gross
what
mass.
any GI losses, any gastroenteritis, vomiting.
Yes, ma'am. Yes, there was intermittent history of loose motions were also there intermittently, but it was subsiding on its own. It was not like a persistent or chronically, but he used to get intermittent episodes of loose motions.
So that is one thing
Starting at what age of life? Starting at what age? The loose motions history.
It was not, well, they were
What
not
age
sure.
is that?
When they came to us, they were telling like in the infantile age also he had this one episode, and later on it was more frequent, like 3 to 4 episodes, but it was not like a chronic or persistent diarrhea.
Yeah.
Okay.
For now, analysis wise, we have only the system involved, but we cannot.
Yeah, so
Combine
we feel
together.
that probably this is something which is probably has some immunological background, something that has started very early in the child's life, some inherent problem,
In the first 3
and
months.
compounded by a poor diet, a nutritional deficiency. GI losses per se, we are not able to corroborate on the basis of what you are giving us. And the CNS irritability, etc., could be contributed by the dietary component, the micronutrient deficiency, the anemia probably.
Even the rash can be also having some micronutrient deficiency component in it.
Or an immunological component.
Both together.
At 3 months.
Yeah.
Okay,
Immunological, something immunological.
Starting so early.
Can we have the anthropometry for this child, whether it is,
Yes, ma'am. Yes.
right and
we'll go ahead
So-
with the exam.
So on an examination, for 4.5 years, his heart rate was around 110 per minute, systolic blood pressure 100, respiratory rate was around 24 minutes, and he was admitted in special room actually, not in this thing. He was irritable, but he was comfortable with the parents. Among anthropometry, his weight was around 12 kg, height 93 centimeters, and head circumference 47.5 centimeters. There was generalized anasarca, facial puffiness, ascites. There was pitting edema present on the face, limbs, and abdominal wall. Rash, it was dry, ichthyotic, stretch, associated cracked skin was there, and skin peeling on the abdomen, chest wall, and the limbs.
You said there were no history of seizures, right?
No, sir, no.
No history of seizures.
No.
I was thinking with the rash and biotinidine deficiency.
How are the joints and bones? How are the joints of this child?
Ma'am, when we
was
try
there
to,
problem
when
with
we
the
try,
hair, eyes, and the nails, hair, eyes, and the joints. How were the joints? Were they was there stiffness, etc.?
this looks like
this was the rash. I'll come to that. It's there in the this question in the leg. This was the rash. You can see the erythematous with some elevation above the skin and peeling of the skin also. Associated distension of the abdomen. It's there on the limbs also.
Yes. Ascites, as in umbilicus.
Yeah. These are the limbs. The pitting kind of edema also there. Nails also you can see now. Some pallor is also there. And joints, you are asking, ma'am, the child was very irritable, was not allowing to examine also. Whether it was painful or not, but mostly it was because of painful, and he was scared to because He visited so many hospitals and he was very scared. Was not allowing us to examine properly also.
Very dry, very.
There is little redness which can be noticed on the little, foot and at the knee.
Yes, madam.
Was there any redness? No.
No, madam. It was just edema and the rash was there.
Okay.
And you can
No
see the
painful
face.
movements of the limbs.
No, ma'am, it was very painful. He was not moving. Most of the time, he prefers to lie on the bed. He was not allowing us to move his limbs. That's why he used to prefer to sit and not able to stand and walk. And you can see the
any dysmorphism, because you have blocked the picture completely. Any dysmorphism here?
No, madam, no. This is just to
The
block
eyes.
the identity, what we say. So the eyes were normal. Hairs, you can see easily pluckable, sparse kind of
Yeah,
hairs.
sparse.
Yeah, facial puffiness is also there, and the irritable look. He was never comfortable.
See, basically, his joints painful, everything can fit into vitamin C, also deficiency along with this easily pluckable hair, and his overall appearance is like an kwashiorkor, I would say. It is anasarca generalized with a pitting edema.
Very rightly said, madam. Rightly said. The features were fitting into the vitamin C deficiency along with
And also thiamine deficiency.
Thiamine.
Yes.
Thiamine
Yes.
B12
Yes,
deficiency.
associated micronutrient deficiency with some protein calorie deficit. So rest of the examination associated few small cervical and axillary lymph nodes which were non-tender. Child was very irritable, not allowing good examination. Few old pyoderma marks on the limbs we have seen. Hair sparse, golden black color, no joint swelling actually, but it was a painful movement of the limbs actually. But we are not very sure whether it was joint or not allowing to examine the limbs. Widening of the wrist, post-control prominence notice. So unfortunately, I don't have the X-rays right now, but clinically there was associated widening of the wrist and prominence of the post-control junctions were seen clinically.
So most of the findings.
Just
please go ahead.
Go ahead.
So most of these findings can be explained by
The
PM.
multiple deficiencies.
Yeah, protein energy
malnutrition. But to combine like from the onset since onset since birth, almost since birth, and neurologic involvement, you have to think of some inborn errors involving vitamin deficiency like thiamine also.
Okay.
Thiamine.
Let's see the next.
Since there is no seizure, then biotinidase becomes less likely. No seizure.
Yes, sir. Yes, right. In the neurological examination,
And
higher.
For the anasarca part of the story, we don't have other systems involved. Like to analyze the thought of anasarca, why is he presenting? We don't have a cardiac involvement.
Yes,
his urine seems to be fine, so that renal involvement out
And
seems
GI
to be
also.
out.
GI
also very occasionally
GI
loose
could be.
stools.
We cannot rule out
It
GI.
may be there, may not be there. And the other one is cardiac we have ruled out, renal we have ruled out.
Hepatic
Almost
also.
with the
Other thing is
hepatic
hepatic.
also does he have anything with regards to manifestation, prolonged bleeding or anything with regards to hepatic? He doesn't have jaundice for sure. So even
there
that
is malnutrition
so
or
it looks
malabsorption.
like that anasarca more into the
Malabsorption.
either the decreased intake along with malabsorption, and if at all some losses from GI.
Malabsorption
That is,
because
I'm not sure.
multiple vitamin D and
Very-
multiple nutrient deficiency.
Very good.
Even iron deficiency can cause malabsorption.
Very good going, ma'am. Already the case is pending and you are almost close to the diagnosis. The approach is absolutely fantastic. Among the neurological examination, higher motor functions were normal. Cranial nerves were normal. Among the motor, there was generalized hypotonia. Power, he was not so cooperative, but poor movements of the legs in the bed. Upper limb, say 5/5, and lower limb, it was 3/5. Reflexes, upper limb normal, lower limb normal to slightly brisk. Plantars were downgoing bilaterally. In the parabdominal, there was abdominal wall edema with skin rash, so no associated guarding rigidity or any organomegaly, and no associated free fluid in the abdomen on the examination. Otherwise, respiratory and cardiac examination was normal. So at this point, already you done with the this thing. You're suspecting some malnutrition with some malabsorption with associated plus minus immunological cause, right, ma'am?
We also like to add zinc deficiency in that micronutrient deficiency because that also definitely presents skin rashes.
Yes,
So
yes,
skin,
yes.
I mean, zinc,
something which is-
thiamine, vitamin C, and vitamin D, and protein. All these are
But
deficient.
onset in the very young.
Yeah, the
first 3
onset
months
in the
of life.
very young age.
Yeah.
And you said baby was breastfed for 5.5 months. Normally, breastfeeding should have taken, not allowed such nutritional symptoms to come so early. So clearly points to something that is hereditary or congenital. So
Yes.
we are looking at some immunological or in
We
probably
cannot just
some hereditary issue. Or
Yes, ma'am. Yes. So,
something
so
that we-
all these thought process was almost the similar thing, ma'am. Why should this child get this at so early age of life, right? Rash, then the edema, then the initial developmental delay. So nothing was. Among the investigations, hemoglobin was 10.9, so there was mild pallor. MCV 86, RDW 17. Total counts 9,800 with 30% poly, 40% lympho, and 13% eosinophils. Platelets were 3.13 lakhs. ESR borderline raised 40. Urine routine microexamination was not significant. Albumin create ratio was 0.8 and stool was also normal, not associated fat globules.
So no proteinuria.
Yeah, so
And
there are no
fat
apparently
losses.
protein losses.
Yes, no
Only
protein loss from the urine.
Eosinophils are slightly.
Or
Eosinophils
even
are
stools.
elevated. Eosinophils are elevated. We can
Yes,
see.
yes, there was some
ESR is,
eosinophil. Yes. LFT, SGOT was 23, SGPT 46, bilirubin total 0.2, direct of 0.1, total protein 4.3 was low, albumin 1.6, and the globulin 2.6, alkaline phosphatase was 449. PT, APT were within normal limit.
So albumin is here to explain
Very
the
low, yeah.
anasarca, I mean the contributory factor for the anasarca or the cause.
But the loss is not renal. because
Yeah.
the
Loss is
ratio
not
only
renal.
0.8.
Loss is not because of liver dysfunction also. So like
Yes,
we
yes.
said.
more of
So there is
fat,
hypoproteinemia.
And the hemoglobin,
Sorry,
the
sir.
hemoglobin is low, but the MTV is normal, so it's not iron deficiency, unlikely to be.
Yes.
Hemoglobin is
10.9.
not so low also to expect so much malabsorption.
RDW is not very high.
Not very high.
So it may be
Yeah,
just the anemia of chronic disease also.
Yeah,
Anemia of
renal
chronic
function,
disease.
creat was 0.15, BUN 12, calcium, total calcium of 4.1 and phosphorus of 3.48. Serum electrolytes, sodium 135, potassium, it's 4.2, sorry, by mistake it is 42, and chloride is 96.
So with severe
Calcium is 4.1.
hypocalcemia.
No.
Yeah.
Yeah.
Hypocalcemia is there. Vitamin D.
Significant hypocalcemia.
You've done vitamin D, vitamin B12 levels.
Yes, yes. Vitamin D level less than 8 nanogram per ml. We did this thing also PTH, it was 96. TTG, IgA and IgA is normal. SCTH and plasma cortisols were normal.
So it's just deficiency.
So basically it points to the deficiency only, including protein and calcium and vitamin D.
Vitamin D
and then
and B also.
B12 not done.
Not done, ma'am. B12 was not done.
What more do you want? Zinc levels also, if we can have.
Yeah, I mean.
So can you
With
please
the-
provide them till now?
With the high,
Sorry,
with
ma'am.
the
Sorry,
high,
sir.
with the high eosinophil count,
No,
and
sir,
this
that
rash,
was the only finding. So skin rash and high eosinophils, that is what we were able to correlate. But
IgE level was normal. IgE level.
yes,
IgE,
yes, sir,
serum
yes, yes.
IgE.
Total and TTG, IgA both were normal.
No, IgE.
No, IgE. IgE among the immunoglobulins.
Hyper IgE
No,
syndrome.
IgE levels we
In
didn't
the-
know, sir. This is what we had with us.
So somehow we are not able to combine it into a single diagnosis.
Something that starts. At
See, because
3
vitamin
months
D
of
deficiency
age.
is so common, we get so much value for every child
Yeah,
almost.
yeah, yeah.
Though the calcium is never so low.
Can it be a part of malnutrition or malabsorption?
Malnutrition 100%.
100% it is there. But
Malnutrition
malabsorption,
100%. Malabsorption, we are not really able to, figure it out from the
So
history.
there can be protein losing enteropathy, but stool that.
But there is no significant history of loose
no,
motions.
they may not
or-
always.
was there any vomiting in the history? I mean, I don't
Not
remember.
really.
No, ma'am,
There
no.
was there any?
Means at times
No.
they said that there were
So GI
associated
losses.
intermittent loose motion was there, but no vomiting. That is what the mother strikingly said. Whatever he was taking, though it was little, he was taking it nicely. Protein
So
losing
maybe some
enteropathy, you
GI
said, sir.
losses.
Sorry?
Yes.
Yeah.
So in that you do that stool for whatever. Stool, you get a test for stool, you test for something.
No. What about ulcerative?
The stool
what
may
about
check in
inflammatory
a-
lesions? Calprotectin.
No, that is
What
for,
about ulcerative?
that is for Crohn's. Right?
Crohn's, yeah. For inflammatory
In protein
lesions of
management,
the
you get
bowel.
something you get, which is very expensive test.
Alpha 1.
Alpha 1, something alpha 1.
And
So
Alpha 1
anything
antigens?
else? Anything else you want to do or want
Only
to
thing, other
perform?
thing about to think about the CNS involvement and malabsorption
CNS
is a rare
CNS
diagnosis.
was normal.
very, I know there is some.
Sorry?
CNS, you're saying dry, very.
No, but it can be this something like you can get this beta lipoproteinemia where you get malabsorption, CNS involvement. In that you
But
get
then you won't
parasitic in peripheral smear. You
So
get
considering this
Fat
neuro regression, we did perform the further neurological workup. EMG NCV, it was performed, it was normal. This was the X-ray. You can see.
This is like
ground
vitamin
glass-
C deficiency.
Yes, ground glass appearance with pencil thin cortex and rest of the classical changes of this thing also you can see over this, the white line of Frankel,
Burger's sign.
rarefaction and all you can see. So this was the old prescription. This child, this one, and it was advised to have some cyclosporin. That is just we put over there. This is what this child has gone in the initial phases, and somebody has advised him beyond steroids, we'll go for cyclosporin. And now at this point, so we are up to like malabsorption, malnutrition, maybe some protein loss somewhere from the body with micronutrient, vitamin C, calcium, vitamin D deficiency. Anything else that is not fitting into this case? Already you have completed the diagnosis. I will say very nicely you have come to an approach and very nicely you have come to the diagnosis also. But anything else like you want to prove the diagnosis now?
What about Scopy? What about
Scopy
Scopy?
and,
A Scopy to
Right.
Scopy and a
right.
biopsy.
GI.
Yeah. So till now the recognized pathology, anasarca, irritability, eczema, atopic dermatitis, severe ricket, atrophic rickets, scurvy, pseudoparalysis. Since we have ruled out the neurological causes, hypoproteinemia, where in this case we still don't know what is the cause of protein loss from this child apart from the poor oral intake, severe PEM, stunting and wasting like Kwashiorkor. So that was very obvious. So we started the treatment, admitted for initial observation and all these things. We started on calcium, vitamin D, then vitamin C, diet with gradual increasing the calories from 500, 600 calorie and then stepped up. Protein intakes initially was increased gradually and we went up to 2 gram per kg per day. And this was on follow-up basis on OPD basis also. Initially he was admitted for initial few days and then discharged and followed on OPD basis. So child lost the edema completely in next 10 days. The weight loss to 10.4 kg. The dermatological lesions subsided in the next 2 weeks. Irritability decreased remarkably and child next follow-up came walking with support. Who initially was brought, was picked up by the father.
Just one question here.
How come
Yes,
everything
It
was
explains the-
3 months? The 3 months we are not able
starting
to
at the
understand.
age of 3 months. It's something what is,
That because
not
of which we are not
fitting.
able to.
Why that skin rashes started at the age of 3 months when the child was breastfed.
So improvement with only
That
diet.
we are still not able to figure it out.
Improvement
Ma'am,
only
can
with
it be-
diet and supplement rules out malabsorption.
Can it be just a rash of atopic dermatitis later on just overlapped with vitamin C deficiency rash? Is it possible? because there is some eosinophilia. There is
from 3 months,
Did
going
not-
on for 4
did
years.
not respond so much to steroids. I didn't know the response to steroids initially.
Yeah, orthotic should have responded to steroids.
Yes, initial phases there was some improvement, not complete improvement. There is some eosinophilia, so maybe some part of atopic dermatitis.
We were completely getting.
No, this rash
So
was
analyzing the-
still, it is something which.
So this is only nutritional.
Sorry
Yeah,
to
so you
step
mean to
in,
say this
but-
was only nutritional?
Sorry to step in, but I think the time is over.
Yes, we'll go ahead quickly with the next few slides. I'll just run over the few slides. They had already diagnosed the case. So initially, you can see initially there had some rash and edema, and later on when it came on follow-up, the edema has almost subsided. You can see the wrinkles, and rash was also getting down. So at this point, is it over? So father asked, when will he grow? So what is your answer? So we'll just go ahead because of time lag. Child was improving. What is the diagnosis? So lots of unanswered question. In a good class patient, vitamin C, vitamin D deficiency, early part of the life, and the hypoproteinemia. So 15 days later, his calcium improved to 6.3, serum proteins 4.45, albumin 1.75. Any more tests for the diagnosis? Upper and lower GI-scopy, rightly you said. Then we went ahead with the biopsy, and it was suggestive of eosinophilic enteritis. Yeah, eosinophilic enteritis. Yeah, so final diagnosis was like atopic dermatitis with allergic enteropathy, malabsorption, where you see the vitamin C deficiency features, calcium, vitamin D deficiency features. So child was later on started on steroids and then followed by cyclosporin as per gastroenterologist advice. He was recovering well. See how nicely later on when he came, he was with better smiling face. So take home, one patient, one disease, try to bring under one umbrella pathology. Low albumin without amino acid deficiency can be urinary loss, like in nephrotic, child not sick, but with multiple nutritional deficiency, poor intake or GI malabsorption. Here in this child, it was both. With liver dysfunction, clinically and lab associated abnormal liver pathology, and he will be a sick child. And multiple nutritional deficiency, maybe poor intake, that is a primary, but not in this upper middle class, and poor absorption, which is a secondary cause. Thank you.
Just one thing. Generally, if they are chronically malnourished, there is some precipitating event that pushes them into something. This child had a presentation only for 15 days. I mean, that anasarca was noticed by the parent only for 15 days, but he didn't have any infective or anything to, kind of just push it into something.
So certain things were very odd in this child, but finally at the end, this is what we were able to make up, and so we thought of putting this case into the discussion. But your approach was absolutely
also important.
Absolutely brilliant, ma'am. Fantastic. Means I will say that so many things were there, but you people didn't miss a single thing. Most of the things were properly covered, except the last cause of arthroscopy, like eosinophilic enteritis. So it was a protein-losing enteropathy.
Dr. Suhas Prabhu, sir, would you like?
Thank you. Again, a very interesting, unusual case.
Rahul, please stop sharing.
I think the approach was very good. First, you say once you have anasarca, you have to think of course, renal causes, which are very easily ruled out. Then you look at the cardiac problem, which of course this patient had no symptoms at all. And of course, the pattern of anasarca in cardiac is quite different from what you see in nephrotic syndrome or hypoalbuminemia. Once you have defined the hypoalbuminemia, and this was very clear here with the serum albumin of 1.6, then you have to see only where has the protein gone. The intake may be poor, there are excessive GI losses, or there is failure to absorb. There can be only three things once you ruled out cardiac and nephrotic causes. The problem really is in diagnosing protein malabsorption. We have good tests for stool fat malabsorption, which is typically what you see, for example, in celiac disease. But protein losing enteropathy of various causes, like this patient with eosinophilic enteritis, is not so easy to define. So it has to be guessed at from the fact that The intake is fairly good, but you can't find any other losses. The liver disease, of course, was ruled out here directly because otherwise that's the other important cause of hypoalbuminemia. So I think the approach was right. Once you have hypoalbuminemia, you are going to look at where the problem lies in the protein in the blood. I think in this case, there were other clues to the malabsorption because this patient also had multiple micronutrient deficiencies, which would be very unusual if you have a renal problem or something like that. I think some clues could have been more defined better earlier. Like I was very interested in the rash, and I wish somebody had showed me a photograph of that rash, what it looked like. And the second important question that I would want to ask, I don't know whether it was not stated, what was the response to the steroid? Somebody gave this child steroid for almost 4 years. There must have been some benefit as a result of which the parents continue to take it. Otherwise, they would not have taken it. And the doctors would not have prescribed it. That itself should have given you a clue that there is some kind of an immunological or allergic thing going on. And that would have helped you to narrow down to the eosinophilic enteritis. So these are my comments. Thank you.
Thank you, sir. Dr. Mahesh Moite, sir, your comments, please.
I think Sir has summed it up very nicely. I was just looking at it with this multiple kind of a symptomatology. At times you get baffled. And of the symptoms, there are few objective, there are few subjective. So I have developed my pattern of first going through the objective symptom. Here, Anasarca was a clearly objective symptom. And as Sir said, there are commonest thing being renal, but this was not looking like renal. Though he was reasonably, though an irritable child. Renal, like nephrotic, is usually a comfortable child, playful child. Liver is always a sick child. Cardiac is always a breathless child. GI at times can baffle you. It can be missed. And here he had a chronic exfoliative skin. And skin is another source of loss of protein from the body. So he perhaps might be losing skin protein from the skin for many years. So this could be skin definitely, but in addition, whether there was anything additional. This being a good class patient, malabsorption or kind of a malnutrition, primary malnutrition is least likely. So that has to be clearly kept in mind. As far as skin pathology, this was started from 3rd month. Unlike the infantile eczema, continued till almost 4 or 5 years with almost severe things. So this was some additional immunological thing going on there, not just skin pathology. This anthropometry was clearly showing chronic malnutrition, the pathology which was started probably from early age, maybe 6 months, 1 year, or maybe 1.5 years. So this was a long-standing pathology with a long-standing skin losses of proteins, and additionally, whether there was any additional source of loss. His photograph, if you see, that was showing a wrist widening. The first photograph which Rahul showed a wrist widening, which was clearly a rickets photograph. Now, PM child with rickets, rarely you may get atrophic rickets, wherein earlier the child was very healthy and then he had malnutrition and he had no time to correct that. But here this child was never healthy. So this was something coming right from the beginning. And in a PM child, the rickets is a second rickets unless otherwise. This child did not have renal pathology. So probably there was a vitamin loss through the GI. In addition, one very interesting thing was the regression of milestone, which were isolated motor. Whenever we get a regression of milestone, usually it's a global delay. It's never isolated motor. Here it was an irritable child with isolated motor. So it had to be antalgic. It was painful, likely, very likely in the given scenario, which was very well proved. As soon as you gave vitamin C to this child, he immediately started walking and standing. So it was deficiency of vitamin C addition. The X-ray which you showed was very classical of vitamin C as well. So now we have protein loss because of Anasarca. We have vitamin D, vitamin C, and vitamin D and vitamin C going together has to be secondary vitamin D and not primary vitamin D. And that is how perhaps you come into a complete loss from the GI. I was just wondering in that direction. And then you go have all the numbers which were going classical in this paper. And not to forget the eosinophilia, which can be because of atrophy, your atopic dermatitis or whatever allergic condition, immunological condition. And then we are expecting some allergic condition in the GI as well. That is how I'll take. Of course, to predict clinically as allergic or eosinophilic enteritis, I don't think that was anybody that could have been anybody's guess. I don't think, but yes, some kind of a generalized malabsorption syndrome, which is existing right since the beginning, complementing with a skin allergic symptom and protein, vitamin D, vitamin C being lost from all the sources. That's how you could have at least guessed at that point of time. Thank you very much.
Thank you. Dr. Mahesh Kore, sir, do you want to add on? I saw your hand.
Yeah. Can I?
Yeah, Mahesh, go ahead. Mahesh, go ahead.
Okay. Like the child has pustular
Mahesh, your internet is unstable.
Okay. Now are you able to?
You mute your video and say only audio.
Yeah.
Like audio.
Okay. Are you able to hear me now?
Yeah, go ahead.
Yes, sir.
Yeah. This child has a rash, which is pustular psoriasis type, right since 3 months of age. And he is from a healthy, wealthy family, means malnutrition is likely. So a rash in an infantile age and persisting for years together has to be an autoinflammatory disorder. And one of the autoinflammatory disorder like DIRA or DITRA will have a pustular psoriasis like rash. And all these symptoms can be explained if the child has high CRP, high ESR, right from the beginning, it will fit into autoinflammatory disorder. And I will ask the treating physician to do his clinical exome sequencing to prove it or to disprove it. One of the pustular psoriasis like rash in an infantile age, we have to think of DIRA or DITRA. If it is urticarial rash, it is Nobel or Sinca, like that. Thank you.
Thank you so much. Thank you so much, sir. Thank you, Rahul, sir, for an interesting case. And thank you and congratulations to Team Thane. So we come to an end of this session too. Dr. Neha, ma'am, I'll request you to please give the vote of thanks.
Yeah, thank you, Shilpa. What a wonderful and interesting cases we had today. Okay, for the vote of thanks now, on behalf of Maha IP, I would like to thank our expert, dear Dr. Subhash Prabhu, sir. Thank you so much, sir, for accepting our invitation for being today's expert. Thank you so much, sir, for your wonderful expert comments and your guidance on how to approach both the cases was very crisp and informative. I would thank our case presenters of today, Dr. Mahesh Kore, sir, and Dr. Rahul Patil, sir, for selecting and presenting such interesting cases. Both the teams, Palghar team and Thane team, have done very well. Good clinical approach. Both the teams, congratulations and thank you for your active participation. Our special thanks to you, Mohite sir, for all your support. I would like to thank our Maha IP President Hemant Gangolia sir, Secretary General Amol Pawar sir, Scientific Convener Dr. Jay Bhandarkar sir, and other EB and OB members of Maha IP. Dr. Sunita Ingle ma'am and Dr. Shilpa, thank you so much for moderating today's case challenge. Also, thank you Pallavi ma'am for all the technical support. Thank you to all the attendees on Zoom and YouTube Live for joining us today. Our next case challenge will be a special one. Will be on 3rd Friday of the next month, that is 21st of October. Requesting everyone to please join. Thank you so much and good night.
Thank